All right, so this is the abdominal lecture. So the muscles of the abdomen, there's 4 layers of the large flat muscles that form the ventral abdominal wall. They're joined at the midline at the tendinous seam. That's the linea alba. So if you look on the picture here, you can see the different 4 layers. So you have, it's very hard to read, but you have the oblique, the external oblique, the rectus abdominis, okay, for pregnant women that usually tears. And then you have the linea alba right down in the center. So again, one set is the rectus abdominis. It forms a strip extending the length of the midline, and its edge is often palpable, so you can feel that. So how do you divide up the abdomen? We talked about this in class. You divide it up into 4 quadrants, horizontal and vertical lines through the umbilicus, or you can also divide it into regions. So you're going to have your epigastric, your umbilical, or your suprapubic, or your hypogastric. Now within the internal anatomy, in your right lower quadrant, what does it contain? Okay, your cecum, your appendix, the ascending colon, and then you have the right ovary, the right ureter, and the right spermatic cord. The right upper quadrant, that contains the liver, the gallbladder, the duodenum, the head of the pancreas, the ascending and transverse colon, and you have the right kidney, which has the adrenal gland on top. The left upper quadrant, what does that contain? That contains your stomach, your spleen, the left lobe of your liver, the pancreas body, the left kidney and adrenal gland, the transverse and descending colon. Your left lower quadrant has your descending colon, your sigmoid colon, the left your ovary, ureter, and spermatic cord. So ATI also breaks up the regions a little bit more. So there's the right hypochondriac, okay, so it has the right lower lobe of the liver, gallbladder, the top portion of the kidney, and part of the duodenum. The right lumbar, so right underneath it, is the ascending colon. The right inguinal region is the cecum, the appendix, the right ureter, ovary, and the right spermatic cord. There's the epigastric region that has your aorta, your pancreas, your pyloric end of the stomach, your umbilical region that has your omentum, meniscere, and the lower part of the duodenum. The hypogastric region, which is the suprapubic region, that's your ileum, the bladder, and uterus. The left hypochondriac region has the stomach, top portion of the kidney, the spleen, the left lumbar, which is right below it, that has the descending colon and kidney. The left inguinal region that has your sigmoid colon, left ureter, ovary, and left spermatic cord. So what is in your internal anatomy midline? So when I mean midline, I mean exactly where the linea alba is, okay? But what's inside? So if you're looking at this picture, what's inside? What can you assess? So you have the aorta, okay? You can assess that. You're looking for pulsations in your inspection. The uterus, if it's enlarged. So if a woman is pregnant, that will be enlarged. The bladder, so if the bladder's distended, you will be able to palpate that. So now let's talk about what does the GI tract consist of. So it starts at the mouth, right? So it's the route that food takes from the mouth to excretion. So chewing our food and swallowing it becomes a food bolus. So it's traveling through the esophagus to the stomach. Now the stomach now processes the food, okay, with the acids and enzymes such as pepsin. Now the food that's digested, it becomes chyme. The pyloric sphincter now opens, allowing the chyme to enter into the small intestine. So if you're looking at this picture, kind of go with the picture. It's just continuous. Now, in the small intestines, digestion, mixing, and absorbing liquefied food occurs. This now travels to the ileocecal valve into the large intestines, okay, which is in the right lower quadrant. And that's where you're going to start listening for bowel sounds, is in the right lower quadrant because of this valve. Now, the large intestines is going to absorb water, nutrients, and it actually helps result it in the form of feces. So now the food is leaving the cecum and it's going through our colon. The sigmoid colon is the last part of our colon. Now this is where the feces is going to pass through the rectum and the anus. Now accessory muscles, or accessory organs that are very important that we need in our GI system. We have our liver. What is the purpose of our liver? The liver has so many different reasons why we have it and different reasons on what it does. So it stores minerals and vitamins for us. It helps us protect against bacteria, detoxification of ingested chemicals, the storage and release of glycogen, carbs, and it metabolizes our proteins. It also helps with our clotting factors and bile, which breaks down fats during digestion. We have our gallbladder, which is kind of tucked in underneath our liver. So this concentrates and stores bile, releases through the common bile duct into the duodenum. The pancreas, what does our pancreas do for us? So it's two different motions. So it has an exocrine, okay, and an endocrine. So the exocrine is enzymes for breakdown of food to fuel. So amylase, lipase, then it's endocrine. Endocrine is for the insulin and the glucagon to regulate our blood sugar and our metabolism. Now with the physiological function, okay, of our GI system is 1, metabolism. We know this. So gastric secretions, it maintains our blood levels, our blood glucose levels, fluid, electrolytes during digestion. Motility, so systemically broken down. Peristalsis, the smooth muscle movements. Secretion, so salivary enzymes, stomach enzymes, and gastric acids to break down food chemically. Then there's digestion and absorption. So breaking large molecules of food down to smaller water-soluble form that it can be absorbed by the blood plasma. The small intestines, they absorb nutrients, okay? Large intestines, they absorb water, vitamins, and minerals. So our primary client that we talk about this semester is aging adults. So what occurs to them? So their appearance of their abdominal wall starts altering. Now the adipose tissue from their arms or face is now going to be redistributed to their abdominal area. So in class we were talking about, like, what about those beer bellies? Okay, now if your uncle, your dad, or your grandpa, or some older gentleman or woman has like a round abdomen and they're older, this is the reason why, because adipose tissue is now redistributed from the face, the arms, and it goes to the abdomen. Their abdominal muscles weaken. These changes, they, again, like we talked about, has that more round, protruding appearance, like that beer belly. So the GI system, okay, there's changes that occur with aging, but most do not significantly affect the function as long as there's no diseases present. Their salivation decreases, so they have a dry mouth, decreased sense of taste. The esophageal emptying is delayed, so you have a higher risk of aspiration when eating laying down, so supine. So what position do you want your client to be when they're eating? You want them really to be in a high phallus position. Okay, if they're eating or drinking, you want them up higher than 30 degrees. Absolutely. They have a decreased gastric secretions, so that could lead to an iron deficiency, anemia, or malabsorption of calcium. pancreatic enzymes decrease. These help with digestion. Incidence of gallstones increases with age. So the liver does decrease, okay, when we age, but the functions remain normal. But that actually affects our drug metabolism. So the drug metabolism is now impaired. They could be more sensitive. The side effects are going to be more increased. Esophageal peristalsis and small intestine motility is decreased, which means they have a higher chance of getting a food bolus stuck, okay, constipation. Okay, so frequent report of constipation. Now, this could be a result of multiple factors. Now, physical activity is decreased. It could be inadequate fluid intake, their fiber diet, side effects of medications that they're taking. If they're not able to get to the bathroom enough, in time, so then they hold their stool, which can cause constipation. So when you're assessing them, first we're getting that subjective data. How is their appetite? Is there a change in their appetite? Do they have a loss of an appetite, or is there an increase in their appetite? Have they had any change in their weight? How much have they gained or lost over what period of time? And then is it due to diet or was it unexpected? Dysphagia. So have they had any difficulty swallowing? So it goes with that. Esophageal peristalsis is decreased. When did they first start noticing it? What type of foods are they eating that they notice that they're having difficulty swallowing? Food intolerance. Is there any foods they can't eat? What happens when they eat them? Do they have an allergic reaction? Do they get heartburn, like that burning sensation that goes into their throat? Do they belch? Is there a lot of bloating in their abdomen, or do they have indigestion? How do they feel after they eat food? Do they take antacids? How often and how much? And which type of antacid taking? Do they have any abdominal history, so any surgeries? Have they had an ulcer, any gallbladder disease, hepatitis, jaundice, appendicitis, colitis? Have they had a hernia? Do they take any medications for any of these stated diseases? And how much? What is it? How often do they take it? Do they take it religiously, or do they forget about it? Have they had any, again, surgeries? And they need to describe it. We don't need to know exactly the year, but if we can get the year, perfect. Have they had any problems after surgery? So was there a complication that they had to have go back in for surgery? When was the last time they had any abdominal x-ray studies? And why did they have them, and what were the results? Do they have any family history of GI cancer or any history of hepatitis? So inflammation of the liver. Do they have any abdominal pain at this moment? We talked about this. So if they have abdominal pain, ask them to point with it with one finger. Exactly where, or is it generalized? And you're going to ask those specific questions, P, Q, R, S, T. So what provoked it? Is the pain in one spot? Does it move around? What's the pain scale on a 0 to 10? How did it start? How long have they had it? Is it constant? Does it come and go? Does it occur before or after the meals? When does it peak? How soon after do they get that pain after they eat? How would they describe it? Is it a cramping? Is it a burning, dull, stabbing, aching pain? Is the pain relieved by food, or is it worse after they eat food? And do they have any of the associated symptoms? So anytime someone has pain, I want to know, do you have anything else with that? Do you have any other symptoms? Nausea, vomiting, diarrhea, rectal pain, rectal bleeding, fever, fatigue, stress, constipation? How is their bowel movements? Now, our clients could have referred pain. So this is just a little description of some ideas on what a referred pain could be. So if someone was having right shoulder pain, it could be maybe their liver. If someone was having left arm pain, okay, it could be their heart. If someone was having more of that right lower quadrant pain, it could be their appendicitis. If it was higher up, it could be appendicitis as well. If they were having like epigastric pain right up here, it could be a peptic ulcer. So again, for the nausea and vomiting, how often, what comes up, how much, what's the color, is there an odor, is it bloody, is there any blood in their vomit at all? Is it associated with like any colicky pain, diarrhea, fever, chills? What food have they eaten in the last 24 hours? Where did you eat? At home, school, restaurant? Did you prepare the food? How did you prepare the food? Is there anyone else at home sick? Have they had any recent travels? So unsanitary water, any food preparation concerns? Now, if they're having heartburn or indigestion, okay, elaborate. Where is it? What does it feel like? What were you eating beforehand? How about any abdominal distension? Does their stomach look bigger than normal? How long? What makes it worse? What makes it better? Any other symptoms? So I want to know about their bowel habits. How often do they have bowel movements? When was their last bowel movement? What was the color, the consistency? Do they ever have black tarry stools or any blood in their urine? I mean, not in their urine, in their stool. Is it bright red blood or is it black? Any diarrhea or constipation? How long has this been going on? And you'll kind of get more information related to the constipation and the diarrhea depending on what they're eating. Any changes in their bowel habits? So have they usually go every day, but then the last 5 days they haven't gone at all? Do they use laxatives? Which ones? How often do they use them? And if they're using laxatives chronically, that can cause constipation. Medications. What type of medications are they taking? This includes over-the-counter medications and herbals. Do they drink alcohol? How much do they drink? When was the last time they drank? Do they smoke? How much do they smoke? For how long? Do they take ibuprofen or aspirin? How much and how often? Because this can actually be a bleeding risk. Nutritional assessment. Now, I want you to think to yourself, what is your diet like? Think about what you eat for breakfast, snack, lunch, snack, lunch. I want you to think about what you're eating. How is your diet? How is your fiber? How's your protein, your carbs? And this is what you're going to do for your patients. You'll ask them, can you tell me what you ate for lunch today? Can you recall breakfast? So, and kind of work your way back, because sometimes they can't remember yesterday, but if you start from like, what is the last thing you ate? What did you eat before that? What about last night? Where do they go shopping? Where do they get their food? So, older adult considerations, we have to think about, okay, how are they getting their groceries? Who prepares their meals? Are they preparing their meals? Do they eat alone or do they share meals with others? Again, asking them what they've eaten for breakfast. Do they have any trouble swallowing with their foods? What do they do right after eating? Do they wait? Do they go for a walk or do they just go straight and lay down? How often do they have their bowel movements? Now with our older adults, we do want to see fiber intake, and this is where you're going to really need to know what your fiber is. And then what do they mean by constipation? Because some older adults think they are constipated, but they're not. But you need to kind of figure out a little bit more details on what they mean by that constipation. Do they take anything for that constipation? Laxatives, Colace, stool softeners? What do they take, and then how often do they use it? And again, if they're doing a chronic laxative, so if they do a daily laxative, that could cause constipation. Okay, so now we're going to prepare for our physical exam because we've done our interview. So you'll need good lighting. Ask the client to urinate prior to examination because you don't want them to be full in their bladder, because then you're palpating the bladder. Tell your patient that you'll be exposing their abdomen, and you'll be exposing them while they're laying supine with their legs slightly bent to relax those abdominal muscles. You're examining the areas that are identified as tender or painful last, so to prevent the guarding and to do a good thorough assessment. Now, what is the order of examination for the abdomen? Inspection, auscultation, percussion, and then palpation. So why this order? So percussion and palpation will alter the bowel sounds if you do them prior to auscultation. Okay, so we're looking at their contour. What does their abdomen look like? You're going to stand on the right side and just look down. And you can also do this while you're walking into the room. But then when you're in the room, just stand on that right side and just kind of look down while you're getting them all ready. You're going to determine the profile. Okay, so you're looking at the contour. It describes the nutritional state. And normally it ranges from flat to round. So expected variations, skyphoid, okay, that concaved in. It could be for a client who has a thinner frame. Obesity, it's a round abdominal with folds along the side. Older adults, they'll have that increased abdominal size due to the redistribution of the adipose tissue. Abnormal contours, so scaphoid caves in, malnourished clients. Protuberant, okay, abdominal distension, that could be gas, tumors, fluid, constipation, obstruction. You're going to measure around the umbilicus while they're supine. So you will sometimes have to measure the width, okay, and the diameter of their abdomen, especially if they're large and they're heavily overweight, or if they're very distended, because if they need to go in for a scan and the scan's only 38 inches wide, but yet they're 42 inches, they're not going to fit. So here is your protuberant. So this gentleman, he looks like he has ascites. That's pretty bad. Okay, inspection. You're looking for symmetry. So here they have a hernia here. Normally symmetric bilaterally, so there's no bulges, there's no masses. Expected variation, so with thinner client, you'll see that aortic pulsations or peristaltic movements. Abnormal, there'll be bulges, masses, hernias, or protrusions from the abdominal wall. Visible, intense pulsations. Now this is if they even have to palpate it. If they have tumors or variant cysts that's very large, or if they're impacted with feces, okay, that's abnormal. Distended with visible peristalsis could indicate a bowel obstruction. So you're looking at the umbilicus, okay, so nowadays it's very common to have a piercing. And normally it's midline and inverted. Okay, there's no signs of discoloration, inflammation, or any hernias. It can become everted and pushed outward with pregnancy. So it's a common site for piercings, okay, but it shouldn't be red or crusted or irritated as this one is. Unexpected redness, swelling, hernias, lesions, any discoloration. So when we're inspecting the skin, we're looking to see if the surface is smooth and even. The color should also be even. Now our stomachs, okay, the abdomen will be a little bit less pigmentation than our other parts of our body due to we protect it from the light from the sun. So if there's fine venous network, it could be visible for our thinner clients. If they have any stretch marks, so like one common pigment change is striae, like a silvery white, the linear jagged marks, okay, those are common with excess weight gain, or could be due to pregnancy, ascites. So let's see, we just talked about that. If they have any lesions, so moles, normally there's no lesions that are present, but if they have a surgical scar, note where the surgical scar is, and also ask them where's the scar from if they mention that they didn't have any surgeries. So again, scars, if they're present, draw its location, okay, in their chart. So if it's in the right lower quadrant, scar in the right lower quadrant, measure in length for the centimeters. Usually they forget about the operation until they see the scar, so just ask about it. Now it could also mean they have some underlying issues because of those surgical scars. So this was a laparoscopic, so they didn't get opened up. They had to use kind of like, if you don't know what a laparoscopic is, it's another way that you can do surgery instead of just doing like one large scar, one large opening. It's more like a computerized, it's kind of like, I think it was like a video game, honestly, because they use the camera and then they use the, like, what are those called? The sticks. What are those called when you remember the old sticks back in the day when we were playing with the video games? What are those? Okay, well, if you don't know what I mean, we'll talk about it in class. Okay, so here is 2 scars. Looks like she had her appendix out, the right lower quadrant, and she had a C-section. Okay, so unexpected findings is there's lesions, bruising, dilated veins, rashes, or yellow skin. Yellow mean jaundice. Glistening taut skin could be ascites. Purple striae, recent stretching of the skin. Could be weight gain from fluid or diet, or it could be pregnancy. Dilated veins, if you can see their veins on their abdomen, could be liver disease. Now also look at their demeanor. How is their demeanor when you walk in the room? So usually they should be comfortable, but if they're kind of like wincing or pacing or rocking back and forth, okay, that could be an indicator of RDM pain. Now we're going to listen. So using the diaphragm and piece, because bowel sounds are relatively like a high pitch. So the diaphragm, you're going to listen to bowel sounds because of the high pitch. You're going to hold lightly, okay, to the skin. Pushing it too hard could actually stimulate bowel sounds. Again, you're starting the right lower quadrant. Because of the ileocecal valve area, the bowel sounds are actually normally present in this area. So evidence shows that if you hear bowel sounds in one quadrant, you don't need to listen to the rest, but I want you guys to practice to go into that clockwise formation. Start in the right lower quadrant, right upper, left lower, because you're going to be inspecting, auscultating, percussing, and palpating in this formation. Now, they could sound different, yes, but if you hear bowel sounds in the right lower quadrant, they're normal active, then chart normal active. So bowel sounds conveyed throughout the abdomen. So again, I want you to start in the right lower quadrant, work in a clockwise formation. So the bowel sounds, it's coming from movement of air or fluid through the small intestines. You're going to note the character and the frequency of the bowels sounds. It all depends on really how long since they've eaten. A wide range of sounds can occur. So they're usually a high-pitched gurgling, cascading sounds. They occur irregularly. They're usually 5 to 30 times per minute, so don't count them, okay? But you're really just going to you're judging on if they're normal, so normal active, hypoactive, or hyperactive. So the baborgismus is the hyperactive rumbling sound heard without the stethoscope. So you can hear kind of the air movement. Hyperactive, that's when they have that increased vowel sounds. They'll be a lot louder and more intense. It's a kind of, think of it like a rushing or a tinkling, okay, like a trickling sound, usually every 3 seconds. Now, what could cause someone to have hyperactive bowel sounds? Now, it could be due to increased GI motility, could have diarrhea, anxiety, bowel inflammation, or an early bowel obstruction. Now, I make a joke of this, but this is very true. When test days, you guys are very anxious, you're nervous about the test, it's a big deal. So a lot of times you're like, oh, my stomach hurts. You're on your way to school, you feel the cramping, you feel the rumbling. Okay, you're having hyperactive bowel sounds. Okay, and then you have just a quick run. Okay, you just go to the bathroom real quick. But next time, okay, well, maybe this will work, but take a moment, okay, just listen to your bowel sounds next test. And then you can really understand on what those hyperactive bowel sounds sound like. Now, some people say they go to the bathroom before the test, after the test, or they just don't go at all. But it is known that when people are very anxious and nervous, that they have increased motility. Now, hypoactive, that's going to be more infrequent, quieter, it occurs less than 1 minute. So you really have to listen carefully. Now, what could cause someone to have hypoactive bowel sounds? It could be from abdominal surgery. It could be from medications such as opioids, inflammation of the peritoneum, or the patient could be in a late bowel obstruction. Now, if they're completely silent, which is very uncommon, you must listen. You must listen to confirm it is silent. They have absent bowel sounds for 5 minutes. Okay, you have to put it on your watch. Set your watch, look at the timer, and count for 5 minutes until you determine that they're silent. Now, if we're listening for vascular sounds, are you using the bell or using the diaphragm? You're going to be using the bell. Okay, so you're listening to the abdomen, you're noting any vascular sounds or bruit. So the bruit again is a whooshing sound. Could be due to stenosis, so a narrowing of the artery, or any occlusion to the artery. So you're using firmer pressure with your bell. You're checking over the aorta. Okay, you're going to start below the xiphoid process, work your way down. Now, when you get around, I know in class we said kind of the umbilical area, but really you should go a little bit higher. So you can listen to the renal artery. And when you listen to the renal arteries, okay, let me draw a picture. So when you go down, this is your aorta. Then you're going to branch off. Okay, you're branching off just like in this picture. Okay, you're going to listen to your left renal or your right renal, then listen to your left renal, just like if you're listening to lung sounds, side to side, compare them. You shouldn't hear anything. If you hear a whoosh, okay, a whoosh, then it possibly is a bruit. Okay, now if you do hear a bruit, it's going to be a continuous whoosh sound because there is an obstruction. Okay, there's stenosis or an occlusion of that artery. Usually, again, there's no such sound as present. And if you hear something, you report it to your doctor and the whooshing sound that was heard and the location. So now we're going to percuss. So percussing, remember, drums. You're using 2 fingers and you want to do fingertips to fingertips. Okay, you don't want to go up here because you're just slapping your hand. You want to tap, okay, percuss on the fingertips. So when you're percussing, it's generally going to be tympany, okay? When you're percussing, it's just assessing the density of the abdominal contents to locate organs and to screen for any abdominal fluid or any masses. General tympany is the sound that you should hear. So again, first you're going to palpate or you're going to percuss all 4 quadrants. And your percussing first area is in your your white quadrant, right lower quadrant. So tympany should be more predominant because it's air in the intestines to the surface when the client is more supine. Dullness occurs over the distended bladder, liver, fluid, mass. When you think dull, you should think density, okay? Hyperresonance, this is going to be present with a gaseous distension. So if they have a lot of gas in there, it could be more of that booming sound. Now we're talking about costiovertebral angle tenderness. So you are assessing for the kidneys. So it's an indirect fist percussion, causes the tissues to vibrate instead of producing a sound. So you're assessing the kidney. You're placing one hand over the 12th rib, okay, at that costiovertebral angle on the back. Now we have one in the front, you have one in the back. It should be about 90 degrees. So you're just thumping that hand slightly, okay, and then the patient should just feel a little thud but no pain. Now if they do have pain, they jerk, okay. Usually that's going to indicate that there's inflammation of the kidney, so pyelonephritis. Now palpating. Now when we're palpating the abdomen, you're going to go light, then deep. So first you're going to go in each quadrant, start in the right lower quadrant, and you're going to go about 3 circles in the quadrant, okay? So 1, 2, 3. And you want to get that whole quadrant. You don't want to miss anything. First, you're light, you're going to go about 1 centimeter deep, okay? You should expect some softness, no nodules, no tenders, no guarding. When you're palpating, you want to make sure you're looking at your patient's face, making sure that they're not grimacing. Now, they could say they have no pain, but if they make a face, okay, I would reassess that area and ask them. Now, reassessing doesn't mean you have to repalpate. That could just be asking a simple question. Did that hurt? Oh, yeah, it did hurt a little bit. Okay, can you tell me what it felt like? Oh, sharp. Okay, now you're getting some more information. This is a new finding. Now, what if your patient's ticklish? Okay, they're just like tickling them. You're just like tickling them the whole time. Have them put their hands on themselves. You put your hand over their hand, okay? And then you guys palpate together. Now, after just a couple tries, have the patient take their hand out. They're just getting familiarized with the sensation. Now, when you're doing that light palpation, okay, expected with softness, no nodules, no tender, no guarding. Now, unexpected, there's tenderness. They're possibly guarding. Involuntary rigidity, okay? There's a mass. This could be due to inflammation of the abdominal cavity, that rigidity. The bladder is palpable if full, okay? If their bladder is full and you didn't have them urinate first, you're most likely going to palpate the bladder. Then, after you do light palpation in all 4 quadrants in a clockwise manner, you're going to go to deep. So it's a 2-hand, top hand deep breath. So you're going to go about 1 to 3 inches deep. Okay, so 2.5 to 7.5 centimeters. You're assessing for organ enlargement or any masses. This is more an advanced experience practice, but you guys are going to practice this because the more you do it, the more experienced you will be. Now, if they say their left upper quadrant is tender, okay, you're getting this already in your interview. You want to assess this area last. Why? You want to assess that area last because they're possibly going to be guarding and focusing so much more on that area, and it's already painful. So when you're assessing the other 3 quadrants, they could say everything hurts. But in reality, not everything doesn't hurt. It's just that left upper. Now, if you identify the mass, okay, if you identify anything abnormal, a nodule, a mass, a lump, you have to note the following. Which quadrant? What's the size? Now, you're not going to possibly be able to get a ruler out and actually measure it, but if you can do an estimate, like maybe a golf ball, maybe a penny. Now, what's the shape of it? Consistency. Is it soft, firm, hard? Is it smooth? Is it nodular? Is it movable? Does it move with respirations? Is there a pulse? Okay, is there a pulsatility? Now, when you're palpating that mass, is tenderness. The liver. So this is more, again, of an experience practice, but I want you guys to practice it. So you're going to place your left hand under your person's back, okay, to the 10th to 12th ribs, and lift up to support the abdominal contents, okay? Then you place your right hand on their right upper quadrant, okay, with the fingers parallel to midline. You're going to push deeply down, okay, and under the right costal margin. You'll have your patient take a deep breath, okay, and it's normal to feel the bump, okay, the edge of the liver, bump your fingertips as the diaphragm pushes it out during inhalation. It should feel like a firm, regular ridge, but often the liver is not palpable. Now in class we were able to palpate some people's livers, but we really had to kind of get in there. It shouldn't be painful, okay? Once it starts being painful, don't do it. Now, rebound tenderness. This is called the Blumberg sign. So this is an indication of irritation or inflammation in the abdominal cavity, such as appendicitis. What you're going to do is you're going to apply firm pressure for 4 seconds with the hand at a 90-degree angle, okay? You're going in, 4 seconds, hold it, and then let it go. You're releasing the hand, you're seeing the response. Pain can confirm, okay, any peritoneal inflammation such as appendicitis. So our older adults, okay, just to go over it again, on inspection, again, they're going to have more of that subcutaneous abdominal fat near their abdomen and hips because it's getting redistributed away from their extremities. Their abdominal muscles are a lot weaker, so it's going to be thinner, has less tone. In absence of obesity, you may see peristalsis. Because of the thinner, softer abdominal wall, organs actually are able to be more palpated, okay? The liver is easier to palpate. Normally you'll feel the liver edge at or just below the costal margin. With distended lungs and depressed diaphragm, the liver can be palpated lower, but again, usually it's not palpated. The kidneys are easier to palpate. Now, keep in mind, if your client is morbidly overweight, this could be very difficult. So, health promotion with these clients. So, we want to encourage our patients who have any GI issues, okay, any abdominal issues, to encourage moderate exercise, about 30 minutes a day. It helps decrease stress, which can affect our GI, like we talked about. Sedentary, okay, lifestyle, that's a risk for constipation. They're not moving around very much. They're not having good, healthy lifestyle. So older adults, as we know, they're at risk for constipation because of the lack of mobility, their dietary habits, their decreased peristalsis. They should have a balanced diet with whole grains, vegetables, fruits, high fiber to help maintain the colon. They should have about 30 grams a day. So if they're able to have a high fiber, it should be able to increase their peristalsis. It protects from colon cancers. They should have about 8 to 10 glasses of water per day, so about 2 to 3 liters a day. So water does help soften stool, okay, and it's easier to pass. Now they're going to have to do some screenings as we get older. We all do. So if they're older than 50, okay, they're going to have regular screenings unless there's a high risk with family history, then it'll start in their 20s. Especially if they had blood in their stool, they'll get in a stool cult. They might get a flexible sigmoidoscopy, so that's looking at the rectum and the descending colon. A colonoscopy, so that's the rectum and the entire large intestines. A barium enema, so they're going to use this to do an x-ray. Now we want to promote them to use antibiotics. It can be over the counter, okay, or it could just be from yogurt. The purpose of Probiotics is to promote growth of good bacteria in the gut. And it's really important for those who are on antibiotics because the antibiotics can kill off that good flora. And the probiotics helps promote the growth of that good flora and the good bacteria. Now, we talked about with hyper and hypoactive bowel sounds on if it was a late or early bowel obstruction. But now let's talk about what a bowel obstruction is. So it's a blockage of the bowel by fecal matter. Now, it's not just a little, it's a lot. Now, this could be due to there's a history of previous abdominal surgery with adhesions. Now, with your assessment finding if they have a bowel obstruction, they're subjective data. They're going to be complaining of vomiting, nausea, absence of stool or gas, dehydration, a colicky pain in their stomach. It could be generalized. They could have a fever. When you're looking at them, their stomach is going to be distended, so their abdomen will be distended. Auscultation. So if they're in early bowel obstruction, their bowel sounds will be more hyperactive because the bowels are trying to push out that blockage, trying to push it through. But when it's a late bowel obstruction, okay, they're going to have more hypoactive, or honestly, it could be absent. So how long do you need to listen for if the bowels are to be confirmed absent? 5 minutes, absolutely. Percussion. So keep in mind, there's a lot of gas in there. There's an absence of gas. So they have a lot of pain in there. So they're going to have that hyperresonance sound because of the accumulation of fluid and gas in the bowels. So if you're percussing over the obstruction, okay, that's density. There's a mass there. It's going to sound dull. Their vital signs, they're going to have an increased pulse, decreased blood pressure. Okay, so that's the conclusion of this online lecture, okay? I would like you guys, okay, to go back into your module content, okay, and look at the chapters you need to assess or to read. Do your F.A. Davis, your health assess, go into health assess abdomen. There's case studies in there. There's the quiz. Make sure you guys are doing the quiz. ATI Fundamentals book, chapter 29. It goes over this material as well. Make sure you guys are completing the questions. Do a study guide. If you wish for us to review your study guide to see what your brain's thinking, kind of just to see if you're on the right track, send it to us. We'll look at it or make a meeting with us. Study groups. Do a study group. If you can teach this, if you can practice this, you will do great on the exam. Okay? While you are practicing this with a classmate, talk out loud. I'm listening in the right lower quadrant. Why I started in the right lower quadrant is because the ileocecal valve is here and bowel sounds will be present here. Okay? And then I go in a clockwise manner. Okay, now if they're tender, okay, in the right upper quadrant, I say that last. Why? Because of da 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 da. Do you see what I mean? Then go through auscultation or go through percussion, palpation. Okay, same thing with inspection before you do auscultation. And then always say, I'm doing this because blah, 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 blah. It will help you. If you can teach it and if you can do it, you'll do stellar. Okay? If you have any questions, let us know. And that's it.